everyone for coming to talk. So we're talking today about lead-induced TR, which obviously is a problem that we all sort of see routinely. We're going to kind of talk about the imaging of this and how it can help make kind of good clinical decisions. So a quick kind of one-liner. I can go to my next screen here. Let's see if this works. So your 80-year-old female patient with a single lead pacemaker, or has a single lead pacemaker for complete heart block, now has severe TR and right-sided heart failure. This clinical conundrum, I think it's safe to say, has never had so many possible treatment options as there are now in 2024. Now that we've had advances in EP, structural interventions of the tricuspid valve, and medical therapy, just that stem alone, I would say, probably 10, 15 years ago, there was not this many options. It was, referral for surgery. And now we have sort of different modalities to remove the leads. We have different interventions on the tricuspid valve. So it's kind of hard to know, with just that stem, what the right step is. And so my hope is that with this talk, we can better illustrate the role of echocardiographers in solving this problem. So we're going to talk about the epidemiology and the pathophysiology of cardiac implantable electronic device related TR, or CIED related TR. This is one of the terms that you'll see in the literature. We're going to talk about the approach to TEE imaging. So this is, the imaging talk is kind of directed towards some of our community labs listening. But my hope is that if there are sonographers online and sonographers here, is that the principles are the exact same. That you can apply to when you're scanning transthoracic echo, and same with the cardiology residents. My hope is that after this talk, when you see someone in the ER with severe TR and you want to do a bedside echo, hopefully the principles you see in this talk can be applied. And then very briefly, we'll talk about sort of management approaches, even though it's not the main focus of this talk. And then also, please, I hope it's interactive. So one of the things I like as a viewer of these rounds is when people type in the comments and chat, even though I may not respond to them because I'm presenting, everyone in the room can see the comments. So we like to see the virtual comments. So if you have anything to add out there, please do. I'm going to start with one of my favorite stories in medicine. Okay, so back to 1957. This is when Elvis had just released his first debut single. Canada was like 90 years old, just kind of crazy to think about. The bottom right, there's a picture of Yonge and King Street. And cardiology, like all fields of medicine in this time, was in rapid development. So there's big advances in pediatric cardiac surgery that was allowing for corrective operations of congenital heart disease. As you can see, the first kind of BT shunt surgery was done, I think, around this time. Cardiopulmonary bypass was only 3 years old. And at this time, pacemakers were just starting to kind of be developed. They were AC powered. You had to plug them into the wall, and they were they were obviously not intended to be a long-term treatment solution. These were like temporary, and they were used for things like postoperative heart block, particularly in pediatric surgeries. So this is a famous cardiac surgeon at the time, Dr. Lillehei, who was practicing out of Minneapolis, and so he was routinely doing these corrective surgeries in pediatric patients and then taking care of them post-operatively. So I want you guys to imagine you're Dr. Lillehei. You've just done a crazy day of exhaustive surgeries. Now you're rounding in the evening in the ICU. You're seeing all these cute kids that you've just done surgery on. They're all connected to the wall, to these big, heavy pacemakers. And you're meeting with the family. You're hoping they're going to do well. And then the lights go out. So this is Halloween in 1957. There was an explosion at a power plant. I think it was like either one or two power plants. It was kind of crazy. And then the hospital actually lost power. So imagine being in the ICU and suddenly 3 or 4 of the kids that you're taking care of suddenly go asystolic at the exact same time. And the only thing you have is epi to just blast. So unfortunately, one of them died. I think maybe more than one of them died at the same time, right in front of everybody. So, you can imagine how awful that was. Obviously, these are kids. And so the next day, the surgeon found the hospital custodian at the time. So this is a guy called Earl Backen, who was this like tinkerer and inventor and kind of like a nerdy guy who loved building things. Your archetypical engineer, ran a shop out of his garage. And Dr. Lillehei, the surgeon, said, we have to invent something. We can't let this happen again. Some kind of battery-powered pacemaker. We have to fix this. Can you do this? So Earl Backen loved these popular mechanics magazines, and he recalled seeing the design of a metronome in one of them. And he's like, you know what, I can probably come up with a prototype that delivers an impulse at a certain tempo or BPM in the same way a metronome does for musicians. So we came up with a prototype. They tested it in the hospital lab on a dog. It worked well. So he went back to his office, to his garage, and started coming up with designs for something to be used in a person. The very next day after that trial in a dog, he goes back to the hospital and he sees a kid with it hooked up. And the surgeon was like, I'm not taking any more chances. We're never losing a kid ever again. So Earl Bakke decides to patent this invention, and he founds a company. And if you guys don't already know, that's how Medtronic was started. That's how the largest pacemaker company in the world was started. It was started with this kind of cool backstory, from tragedy. So fast forward now, 67 years later, more than 1 million pacemakers go in yearly. And kind of by default, until very recently, ventricular pacing leads, or ICD leads, have to pass through the tricuspid valve. And these leads are placed in the EP lab under fluoroscopy, and there's not really regular intracardiac imaging. In 1974, that was the first ever case report of TR caused by a pacing lead, and diagnosed via a murmur when the patient developed heart failure and died. And then on autopsy, they actually found the perforated lead, perforated by the pacing lead. Now that echocardiography is obviously much more developed, it's the workhorse for diagnosing valve disease. Lead-induced TR has slowly become more recognized, and the overall prevalence seems to be stable over time. This is a slide from Andrew Ha, who's one of the EP docs at UHN, that shows that the prevalence in TR is just under 20%. We're talking about all TR in patients with pacing leads. The most recent study coming from Australia's national database of echo, there's like 10,000 patients in there, and so there's 1 million patients in there, and then 10,000 patients with pacemakers. About 24% of them have some kind of lead-associated TR. Okay, Dr. Chan?
Nope, trying to hide things.
Oh, okay, no worries. Okay.
Not that easy.
Quickly, let's talk nomenclature. So this is a proposed system for describing the causality of the lead in TR. So if you look towards the right, there's something called lead-related TR. This is how we describe TR that's directly caused by the RV lead, and it's defined by any TR of any grade appearing after lead insertion or pre-existing TR worsening following lead insertion. Or when you have imaging that clearly shows a lead-leaflet interaction. So that's lead-related TR. Then on the left there is lead-associated TR when there's no clear positive relationship. I'll be honest, I'm not a fan of this nomenclature. I think associated and lead, or associated and related sound too similar. I think it should have been called lead-induced TR versus lead-associated TR. But anyways, that's just my personal annoyance with this. And so the data shows that when you have a lead that directly causes TR, that really accelerates the evolution more so than sort of the natural history of non-lead related TR. CIED-related TR is this umbrella term that you'll also see in the literature being used to describe all sorts of lead-related TR. This is that paper from Australia, just again, another prevalence, just to show you the prevalence. So of I don't know if you can see my cursor there, of something like 18,000 individuals with pacemakers, less than half of them have no or trivial TR. 29% have mild TR, and then more than 20% have either moderate or severe TR. This is just an all comers. And similar to just TR, the worse TR that you have, the worse survival you have. The presence of a lead seems to maybe increase, maybe be an independent predictor for mortality in these patients. There's actually not a ton of great data out there for non-mortality data, such as heart failure and etc. But in general, the available papers show that lead-related severe TR has been linked to nearly double the risk of heart failure hospitalization, tricuspid valve surgery, CRT upgrading, etc. So long story short, there's a nomenclature difference, associated versus related TR. In general, lead-associated TR is relatively common, and it's bad. It increases the risk of heart failure and maybe mortality. Do we know the risk factors for developing this? So unfortunately, again, the quality is not great in terms of the data. This is one paper of about 1,000 patients that separated them into patients with no RV dilatation or patients with RV dilatation at baseline. So if you have a normal RV and you're getting a pacemaker lead, about 1 in 4 patients will have worsening TR by at least 1 grade. So from pre to post implantation, from mild to moderate or moderate to severe in follow-up. If you have a dilated RV, that number actually doubles. So it's almost half. 46% of patients have worsened TR by 1 grade. And if you just look at prevalence data, about 2/3 of these patients will have moderate or greater TR. And progression of TR was shown by these guys to be an independent predictor of 10-year survival as well. So that's one risk factor that, if you're putting in an RV lead in someone whose RV is already dilated, you should know that, there is a good chance that their TR will progress over time. There are other risk factors that have been sort of proposed out there. So I'll just show you. So lead numbers. So if, once in a while you see patients with 1 or 2 leads, and there's something wrong with the lead, either fracture, and you're debating putting another lead, that is a risk factor maybe. There's some clinical factors that are associated with TR progression, previous lead extraction, and then I'll just talk about these bottom 2 here. So the placement of the actual lead has been discussed. So my understanding is there's a couple of different ways to cross the lead, to cross the valve. You can either let the lead prolapse into the RV, or you can kind of directly cross it. There may be slightly more risk with directly crossing. And then a group has looked at sort of the angle at which the lead passes through the valve. So this is a kind of a diagram of the angle of the lead on chest X-ray, whether it points down towards the apex or up towards the septum, for example, for septal pacing. And so one group out there purported that if you have sort of septal pacing, that might put extra strain on the posterior leaflet here, and maybe that increases the risk of developing TR. There was a randomized trial that looked at apical versus septal pacing, and they didn't really find any big difference. So, and the group in Ottawa actually has published a small paper looking at lead slack, maybe the amount of slack of the lead when they place it has some kind of impinging effect. There isn't strong, really, risk factors, or at least we haven't identified them yet in terms of what really puts someone at high risk for developing TR. So, bottom line, short, more data is needed. The mechanisms, let's talk about the mechanism now. So it is complex. So intuitively, what we think about is when you have a lead in there, there's going to be mechanical interference touching a leaflet, preventing the leaflets from closing properly, right? So lead-related mechanical interference of lead coaptation. But there's actually other mechanisms of TR from this. So you can have pacing-induced TR just by the dysynchrony between the ventricles. You can have valve dysfunction following lead extraction, lead endocarditis. And then chronic pacing of the RV, you can get this kind of RV failure and dilatation and remodeling. Beyond, if you just focus in on the mechanical interference component, then it gets even more kind of complex. So you can have impingement, so direct contact of that leaflet preventing coaptation during systole, that's the definition. You can get adherence, where the lead gets stuck to the leaflet and the subvalve or the subvalvular apparatus, just getting fibrosis and then this over time. You can have perforation or laceration during placement. Or as I kind of mentioned, the lead can actually get entangled in the chordae and the subvalvular apparatus, leading to sort of tethering. So even the mechanism of the mechanical interference can be a little complex. Rarely you can have avulsion as well during lead extraction, where you actually can transect papillary muscles or chordae or tendinate. So good TE interrogation is very key here in determining what the actual mechanism of TR is. Okay, so that's my preamble. Let's get into some pictures here. I'm going to talk about the kind of 3-step approach we have at St. Michael's to the tricuspid valve when we're in the TE room. First, identify the leaflet anatomy. Second, identify the lead position and course through the valve. And third, identify the lead leaflet pathology. And the reason we're talking about this today is if you can do these 3 things, you directly impact what the available treatment options are. And the key tools or the key views you're going to be using here are the transgastric view and the mid-esophageal view at 60 degrees. And the tools you use are 2D, sweeps, X-plane, and 3D. And again, I know this is TE focused, but what you'll see here, hopefully you can directly apply to transthoracic echo as well. And I'll show some examples of transthoracic echo here. So let's start here. Step 1, identify the leaflet anatomy. TE allows you to see all the leaflets in the tricuspid valve. And this view in particular, this is the only view where you can reliably see all the available leaflets. In this view, you're at the transgastric view at around 30 to 45 degrees. So I want you to imagine that you're standing at the patient's feet and you're looking up through their, through their chest. The mitral valve would be on the right side here or so. So step 1, identify the leaflets. So the T probe is posterior to the heart. So anything at the top of the screen is posterior. So we have these three leaflets: the anterior, the posterior, and the septal leaflet. I'm realizing now my cursor actually is not calibrated to the screen. I don't know why. I'm not pointing to the. I'm gonna have to look to the screen where I point. So sorry about that. That threw people off. But so the anterior leaflet, posterior leaflet, and the septal leaflet. The next thing is you identify the commissures. So you have the anteroposterior commissure, the posterior-septal commissure, you have the anteroseptal here, and then you identify the lead, obviously, which is the kind of, you can see it in the middle there, bouncing the lead with some associated ring or reverberation artifact. Now, as we all know, this is from the seminal paper by Hahn et al. Turns out only half the time the tricuspid valve has three leaflets. This is the sort of nomenclature and classification that's been proposed. So the blue circle that you see here is the anterior papillary muscle. Oh, sorry. Is the anterior papillary muscle that is your differentiation point between the anterior and the posterior leaflet. So you'll see that on X-Men. I'll show you that in a second. This is a type 1 regular tri-leaflet tricuspid valve. Well, 5% of the time it can be bicuspid. Most commonly is this quadricuspid or 4-leaflet configuration. And again, the location of the papillary muscle helps you determine whether there's 2 anterior cusps, leaflets, 2 posterior leaflets, or 2 septal leaflets. And then you can also have a type 5 leaflet where there's 5 or more cusps. The tricuspid valve can get relatively complex. So here's an example. If you see here by looking at, hopefully in the Zoom, it's relatively good frame rate out there, but you can see here that there are 4 leaflets, the anterior, the septal, and then we've defined this as P1 and P2. And the reason we're calling that P1 and P2 is if you put an X-plane down through the anteroposterior commissure here, you can see there is your papillary muscle. So now you have, this is a type 3B tricuspid valve according to that configuration. So, Ammon, thank you for the comment there. That's kind of my next slide. Can you reliably identify tricuspid valve anatomy with TTE? So, I think I'm not sure. The previous center that I was training at, this was on the wall here. This is from a study that shows different views on transthoracic echo and what's the likelihood of which leaflet you're looking at, the relative prevalence. This is obviously highly dependent on the view. It requires a lot of sweeps. Catherine Otto kind of alluded to this in her textbook, saying that depending on a certain view, the tricuspid leaflet adjacent to the free wall might be the anterior, the posterior leaflet, depending on the exact rotation. Problem is, half the time there are 4 leaflets, or there's more. There are either or 2 leaflets or more. So I think it can be very tricky, and I'll show an example later on of some transthoracics. But it can be tricky with transthoracic. Okay, step 2. Identify the lead position and the course of the tricuspid valve. So here's a case, and I think the core message here, which if you're not doing this out there virtually, I really highly recommend you do, is you place an X-plane directly through the lead, and this is what allows you to understand the course of the lead, the complete visualization of the lead. So as I mentioned, posterior and anterior is kind of away from the screen and towards the screen, as you see here. So if you look on the left, you can see the lead is kind of floating in the middle of the valve here. So I would say that the lead passes centrally through the valve. And then on the right, oh, sorry, again, my cursor is mistaken here. But on the right here, you can see that the lead traverses posteriorly through the valve and through the ventricle. Here are your leaflets. And as with the X-plane, as you can see here, we're catching the anterior and the posterior leaflet here. Here's another example. So identify your leaflets, anterior, posterior, septal, identify your commissures, and then you can see, hopefully, the lead is hanging out in the posterior septal commissure. It's moving well. It looks very free. And when you X-plane directly through the lead, as best as you can, show you a picture here, you can hopefully see that the lead, again, passes and traverses very posteriorly. It almost hugs the wall. So I would say that this lead passes through the posterior septal commissure and traverses posteriorly. Here's another example. You can see the lead is, again, kind of bouncing in the center, maybe a little bit towards the kind of posterior septal commissure. This time, when we X-plane through the lead, it actually traverses very anteriorly. It's almost going towards the RV outflow tract when you X-plane this. And so understanding the traversal of the lead is also very important to describe. Okay, step 3, identifying the pathology. So this is where very careful X-plane looking for lead motion and then lead leaflet and lead chordal interaction is important. X-plane with color to identify the origin of the TR jet can help. And then 3D and MPR are also extremely helpful. And we're trying to identify those potential etiologies that we saw: impingement, adherence, perforation, and then all the other causes of TR as well. Is there malcoaptation or coaptation gap? Is there endocarditis? Is there a torn chordae or a flail leaflet, etc.? So in that first case that we looked at, so this is where the leaflet is passing through the center of the valve, you can see that the lead, it seems to be moving well. It doesn't seem to be attached or touching any of the leaflets or adherent to any of them. And now when we use X-plane with color, we see that there is a huge jet. It's not really originating at any sort of lead leaflet interaction, and so we would call the primary mechanism of this. It's a malcoaptation gap. This patient had sort of ventricular functional TR. It might be put into that category of lead associated TR. So no obvious lead leaflet interaction here. As a caveat, and Howard would mention, or Dr. Leon Point mentions this to us whenever we see this, is that it can be difficult in the end stages of TR to determine whether lead related or lead induced TR was present, because if you have a lead that pushes against the anterior leaflet causing TR, as the RV remodels, the annulus dilates, the leaflets get pulled apart, and so at some point it can be very tricky to know if that was present at some point. Okay, let's look at more cases. Okay, so this is another view. So again, on the left, we're looking at that transgastric view. We're going to identify our leaflets, septal, posterior, anterior. So we can see here that the lead passes maybe centrally, maybe a little bit kind of posterior or septally. And then when we look on the X-plane, we see that it traverses posteriorly. The leaflets are, opening nicely. There's our X-plane, and we see the posterior and the anterior, posterior and anterior leaflet here. Now, when we use color, we see that there's a jet directly arising from where the leaflets might be touching the lead. Very suspicious. So this is what this suggests, that there is some form of lead-related or lead-induced TR. So let's look a little further and see if we can actually get proof. So this is now, we've moved to the mid-esophageal view or the tricommissural view. So for the residents, because you haven't seen this too much TE, this view, the way that I see it, is kind of like an upside down parasternal short axis at the level of the aortic valve. So you see ideally two leaflets at any given time on the left side, the anterior and the posterior leaflet, and then when you X-plane through, you should see that leaflet and the septal leaflet. Again, if you have 4 leaflets, it can be a little bit more challenging when you're imaging in this view. But here again, you see that the TR seems to be originating from the interaction with the septal and that posterior leaflet in systole. Clearly there's a jet. We're still not seeing impingement, obviously. So what are the other tools that we have? So next is 3D. So this is what the kind of 3D construction looked like. So again, we see, confirms what we saw in 2D, that the leaflet is kind of, if not centrally, a little bit towards the posterior septal commissure. Again, not seeing any slam dunk impingement per se. Here's where the color is originating from, right from that, from where the lead might be interacting with the leaflet. So the next tool we use in TE is MPR. So this can be very helpful. So in this MPR setup, as you can see, the axes are unlocked. We have placed the red axis directly along the lead. We've placed the green axis as well directly along the lead. And if you look in the bottom left here, we try to orient the axis so that we look at the potential area of interaction. So here is the lead and the posterior leaflet here. Actually, I should have some labels show up here. There we go. And so now if you look in the green box up here, you can kind of make out that the leaflets are not coapting symmetrically. In fact, this posterior leaflet, if I can get the video to play again, it seems to be impinged. You can actually see here that it's, whether it's a leaflet or maybe it's actually touching the chordae as well, it's preventing closure. Right there. And so if we look at color, that's exactly where the color is coming from. And so it actually took a couple of tools, as you can see here, to actually nail down the diagnosis here for impingement. So this is how we would describe this in our report. The lead is passing centrally through the annulus, traversing posteriorly, and then there's evidence of impingement on that septal aspect of the posterior leaflet preventing coaptation. And that's our conclusion. Okay, next case. So this is again, starting at the transgastric view, we identify our leaflets. So here already we're kind of starting to see something kind of interesting. So the lead appears tucked in to the posterior septal commissure there. It looks very rigid, right? It's not moving as much. Additionally, if you look at the posterior leaflet here, it doesn't really look like it's moving or moving towards coaptation at all. Plus, you see all these kind of curved, echo densities here, kind of all bending in and touching the lead. Almost looks like a little spider sitting in the corner there. If you look at the TR, you see there it's clearly originating from this massive central coaptation gap, not really coming from the lead per se. Maybe there's coming from the massive central coaptation gap. Maybe there's a smaller jet coming from here. The majority of the TR is clearly coming away from the lead, however. As we explain, again, directly through the lead, here's what we see. Very, very interesting. It courses posteriorly, but you can also notice that the posterior leaflet here is like completely fixed. It looks frozen. It's not. It looks stuck to the lead. Even the lead's got this strange bend to it. It's bending back. It's got this kind of S shape almost. This is just to kind of highlight again. I've kind of put a little diagram. There's a lead, and then you can see that the posterior leaflet is kind of there and doesn't seem to be moving. Back to this is the mid-esophageal view at 60 degrees. So again, we're explaining directly through the lead, and we see here clearly that do I have my labels out here? You can see here that the septal and the posterior leaflet they're adhered. They're clearly stuck to the here. They're clearly, as you can see, stuck to this to the lead here.
It's almost like a mitral clip.
Yeah, exactly. Dr. Haas said it looks almost like a mitral clip. Now, on the left here, we're back. We're still at the 60-degree view here. We're now placing X-plane through the anterior leaflet here, and on the right, this is the anterior and septal leaflet. So you can actually see there is there's the coaptation gap that we saw in the transgastric view. So in this case, we have multiple mechanisms of TR, not just the lead adhesion that's causing malcoaptation in that area, but there's also annular dilatation and this large central coaptation gap between the anteroseptal and posteroseptal leaflets. Okay, next case. Another case here. We're starting in the transgastric view. We identify our leaflets. We see the lead here is kind of stuck, or it's kind of against the septal leaflet there. It's tucked into the, maybe towards the posteroseptal commissure. You can kind of make out that there's already probably a coaptation gap in the center of the valve. This is now back to the mid-esophageal view at 60 degrees. Again, not really seeing the mechanism here, but it looks, more closer to the posterior side. We're seeing, here's color compare with color. Again, mechanism's not well seen, but we're seeing a large jet coming from around where the lead is touching the posterior leaflet there. And then when we look on 3D, we actually see that it indeed looks like the lead has perforated the septal leaflet. Unfortunately, we don't have OR evidence of this. I think the patient was, she was quite old, and I think she ended up getting palliated. But highly, highly suspicious for septal perforation. So the principles here are: describe the passage through the valve and the traversal direction, explain directly through the lead. If you see a jet coming from where the lead and the leaflet interaction, that's highly suspicious for lead-related TR, and you look for abnormal leaflet motion or any asymmetry in coaptation. So is this possible with transthoracic echo? So I'll show you a study here done by one of our sonographers. Shout out Matthew, great job on this study. Where first of all, I got great views. That's the big limitation. But here you can see. Well, we'll take a look. So this is the RV inflow view. This playing again here. We're seeing a leaflet here that's sort of more posterior. This is more anterior. We see that he's managed to get the lead completely in view. So getting this view is very, very helpful, because again, at this point we can try and see whether there's lead-leaflet interaction allowed by when you get a view that shows the whole lead in one line. Okay, so I don't know, what do you guys think? Do you guys see any lead impingement there? I see a lead that's kind of opening and closing. Let's go to the next slide here. Again, leaflet, you get the sense that there's a gap between those two leaflets. Tough to say, is there any obvious lead-leaflet interaction? Right? Tough to say. With slight panning towards, away from the septum, now we don't see the lead anymore. We still see two leaflets. We still see a coaptation gap. And with color, obviously, there's a big jet. Again, not from where we see lead-leaflet interaction. And then thank you for the comment. Yes, we'll talk about the subclassical view in a second. So this is a sweep. So we're starting from the kind of LVOT. So in the bottom left here, we're seeing the mitral valve. This is the LVOT, and we're sweeping kind of from the septum away. So the first. Oh, sorry, 1 second. I'll go back. So the first leaflet you'll see here is probably the septal leaflet. We see, as the sweep continues, you see the lead come into view and then disappear, and then we see the next leaflet. We don't actually see any, leaflet being bent back by the lead, out here, or a major or the most amount of TR coming from this kind of frame here. We just kind of see it pass through, and then we see the next leaflet. Again, clearly tethered. The leaflets are tethered. There's a large central coaptation gap. That's all there. We don't truly see lead-leaflet interaction. And so even on this transthoracic echo, when we were reading it, we had a hunch that there probably wasn't going to be lead-related TR, and that this is more likely to be functional TR. Here's another view, again, more posterior. So this is the corroborating transesophageal view. Turns out, first of all, it was a quadricuspid valve. Second of all, the lead is indeed tucked into the posterior septal commissure there. There's a large central coaptation gap, and you can see tons and tons and tons and tons of TR. When we explain directly through the lead, we again don't really see. It's tough to see a lot of things in this view, but we don't obviously see impingement. Here's what the 3D looks like. Again, tucked right into the posterior septal commissure, not definitively contributing to the main mechanism of TR here. As you can see, that clearly is coming from this large kind of coaptation gap. So I think bottom line is knowing how we image this in TE, I think can really help when you see a lead in transthoracic, like using those same kind of tools, zoom in, sweep, trying to show the leaflets, trying to show the full lead in a straight line can be actually really helpful and help us make predictions and actually direct our TE as well. The available options to treat TR obviously have expanded. This is a nice kind of graphic where it shows that as the TR gets more and more complicated, we kind of move from clips to TTVR, and then eventually, if TTVR is not possible, then we look into kind of heterotopic valve replacement. And so, what I think doing a really great job in TE helps make this structural decision making, right? So here I'm going to give you some kind of cases and examples. So first question is, can we take a lead out? There's obviously patient-related factors, right? If the patient has complete heart block and needs that pacemaker, well, they can't not have a pacemaker. There might be options, but if on TE, if you identify that lead is completely stuck to the chordae and the papillary muscle, that actually suggests a higher risk of complications. Identifying where the lead is in relation to where the TR is coming from also has implications in getting the actual equipment there. So examples, let's say you have a big gap between the anterior leaflet and the septal leaflet. Well, you'd like to deliver a clip there. If there's a lead actually hanging out in that commissure, bouncing around, that makes it very difficult for the structural guys to put in a clip there. So understanding where that lead is actually, getting in the way of the equipment needed, that's a consideration as well. So this is something we try to answer with TE as well. Will extraction work? So this is another big question. Someone's got a lead in, they have severe TR. Should we take the lead out, put in a leadless pacemaker? Will that solve our problems? Well, if there's a massive central coaptation gap, probably not. There's gaps in evidence, of course, but I'll show you a case after where we had that problem. This is where identifying the number of leaflets is helpful. The more leaflets there are, if you're looking at a quadricuspid valve or a leaflet with with 5 valves or clefts, clips are less likely to succeed in reducing TR. What about jailing the lead? So this is where you're putting in a TTVR, you're blowing it up in the annulus, and you're pushing the lead to one side and pinning it against the kind of annulus. It's possible. We've done that. EP doesn't really like it because it makes removing the lead later on very difficult. So let's say you get endocarditis, that's been challenging. And again, we don't have large-scale, long-term follow-up on lead function, for risk of lead fracture due to impingement, et cetera. But that is something that we have done. And then also, again, it helps us rule out different things and maybe lead to potentially going down the road of heterotopic TTVR. Obviously, there's lots of limitations with what I've talked here. Starting with the tricuspid valve is challenging to image at the best of times, especially in TE. The good thing is, as the tricuspid valve gets very diseased and the RV and area get dilated, it actually becomes easier. But for sure, on transthoracic echo, we know it's not easy to see the tricuspid valve often. The lead-leaflet interaction is not always clear. Indeed, sometimes you hunt and you can't really definitively say whether there is lead-leaflet interaction. It does take a long time to properly interrogate. I know in some of the labs out there, you guys are doing 5 or 6 TEs per day, and it's not you don't have the luxury of spending an hour on the tricuspid valve like I do, annoying our that's an hour for his health. So it's certainly not feasible always. We totally get that. As we mentioned before, chronic lead-related TR can be indistinguishable from lead-associated TR. So just dilation from other pathology. And of course, we have lots of gaps in evidence here of translating these imaging findings to decision making. Now that we've established, for example, as I said, adherence means that there's higher risk. We're still waiting on filling in those gaps of evidence. Here's one more case again of another patient. So you can see here the lead is kind of bouncing around. It looks free. It's in the center of the valve. There's TR coming from around the valve. So first kind of clue like, okay, maybe this may not be purely lead related. You can see that, hopefully you can see that it courses anteriorly. If you had to guess here, is there lead-leaflet interaction? Is it interacting with the subvalvular apparatus there? Maybe on the right side, is it touching one of the chordae or the papillary muscle? Hard to say, right? Like it's not obvious. And in this case, the lead was taken out. Guess what? Still left with a big central coaptation gap. As you can see here, the leaflets are very, very tethered, which you can probably kind of tell even on the kind of first imaging that I showed you, but severe TR. Obviously, there are more factors than just the imaging here. And so, there's lots of these algorithms that are out there, all kind of basically saying the same thing. You need to have lots of people, a lot of colleagues in the boat. You need a hard team approach. So, can the lead be taken out? Is the patient medically optimized? Are they a surgical candidate? What does the anatomy look like for other options? And given, as I said, all the options, you need to have sort of a good discussion. So out there, getting EP on board, knowing what your center is capable of. For sure, when these patients come here, we have a sort of hard team approach we discuss with our structuralists and our surgeons. We get EP on board as well. So these are still complex patients. We're still trying to figure out what the right way and the best way to treat these patients is. And finally, these are just a few examples of sort of some of the treatment options that we've kind of given patients. In the bottom left, you can see this is a tricuspid valve after 3 triclips have been deployed to the anteroseptal commissure there. You can see that the leaflet or the lead is still hanging out here. It's free, and there's still a large orifice, but the degree of TR was reduced massively. And the patient did better. And then in the other two here, these are fluoro pictures of a TTVR where we jailed the lead. You can see that's kind of pushed right out to the side with minimal paravalvular leak. And the patient, I think in this case as well, had a good outcome, and the right side of heart failure symptoms improved. As we said, whether this is sort of a long-term feasible strategy that we should be repeating is sort of in contention. So anyways, in conclusion, CIED-related TR is common. Severe TR leads to bad outcomes. The mechanism behind TR obviously can be diverse. Careful interrogation using all the tools you have in your toolbox as an echocardiographer and sonographer is required to diagnose sort of the most common mechanisms: impingement, adherence, perforation, subvalvular involvement. That 3-step approach of getting the anatomy, getting the lead position on the course, and then identifying lead leaflet pathology is helpful. The better job that we do in trying to identify these mechanisms will more likely lead to the correct decision making being made for our patients. So thank you very much. If there's any questions or chat, or if you want to turn your mic on, please feel free. Thanks so much.
So thank you, Dr. Unni, for presenting this, and it's really fantastic, and it highlights sort of an aspect of where we are in our history of development of echocardiography, where now AI is taking a place in our what we do every day, but then this particular situation highlights the importance of using human intelligence, of actually understanding the anatomy, being tenacious about looking at where things are and how the lead interacts with leaflets and the leaflets anatomy. So there's a lot going in terms of understanding it. Also, speak to our sonographers' ability not only just to get the pictures and I just got it in the severe TR, and really go in other steps of looking for the mechanism, like where's the lead? So how is the lead in relationship with the leaflet? Is it impinging the leaflets, or is it affecting the subalveolar structure? So lots of panning and sweeping to get these images. I'll shout out to Matthew, as one of our new addition to our Echo Lab who did that. It's really fantastic. Another interesting observation is that in conversations with my EP colleagues, and many of them have this thing going on about denial of this actually happening. I think deep inside they're still denying that lead-related TR is happening. So anyway, just a side discussion, and maybe I'll just start a question that I always have. So given about 20% of people may have lead-related tricuspid regurgitation, and then and the increase of TR, and these leads are in your body pretty much all your life. Once it's in there, should we just do leadless pacemaker?
That is a great question, and I wish we had. There's no EP. It's a great question. It's a great question. I think first of all, just to clarify, that 20%, I think that does include. Half of that, so about 10% of that in total will have none or trace or trace or mild TR. So of all pacemaker leads, it'll be around 10% that has either moderate or severe TR. That's a good question. Should everyone just get a micra? I think cost is one thing. I think durability is another question. And the third is, interestingly, there is some studies looking at the development of TR after micra insertion. There are definitely reports that are out there. It's not it's not a tiny device. It still is about the size of like a battery, and it can still interfere with the chordae. It's a good question. We should ask someone with, and actually, if anybody in the chat if has an idea, if there's any EP docs, or if you have any insight into at your center, are you just putting in micras in everyone? I'm not sure. I actually do think, though, if you have a patient who's got already moderate TR and a dilated RV, and there's a very good chance that you're going to make that worse with putting in a VVI pacemaker, that might be the right person to actually say, hey, should we put in a micra instead up front?
Yeah. So yes. So one of the mechanism of micra, of the leadless pacemaker, is actually affecting the subalveolar structure, because it could be attached to the subalveolar structure, preventing the coaptation underneath the valve. So that's one reason why it may be challenging. Also, then there's also durability, and how many times you want to put another one in after 10 years, etc. So it's still an area of exploration. I must say that many of my patients are from Asia, and I do see that actually is becoming very popular to be put in Asia in particular.
Eamon had a nice question here about the use of subcostal imaging, especially on short axis, to try and identify leaflet anatomy. It's a go. What do you guys think in terms of? Have you guys been able to get good short axis pictures when you're doing subcostals? Because I have seen it sometimes. You guys get reasonable views of the tricuspid valve. Is it?
Some patients, yes.
Some patients, right? Yeah, it's a good question, actually. I don't know if I've.
It's possible for some others.
It's not our standard view at this point. I mean, by and large, in our transthoracic protocol, but at the same time, I think begs you to actually explore that. So in particular, your patients have a dilated ventricle, tricuspid valve are so much easier to look at. When you have a normal, it's much harder, right? But indeed, when you have a patient with tricuspid regurgitation that's moderate to severe, it begs you to sort of go one step, like in a subcostal, to do your 90-degree views that we don't normally do, and then try to explore that. It's not our standard view, but then in particular with the pacemaker lead, and it allows you to capture additional sweeping views and etc. So these are case by case basis. That's why we need you to be out there to help us to get the images. So again, can't emphasize how important our sonographer colleague is to us, because you are our hands, eye, ears, and everything else.
Excuse me.
Yep, go ahead.
If I can mention, at our hospital where I used to work at the Hamilton General, we in fact picked up a few cases of traumatic induced tricuspid regurgitation from blunt trauma from subcostal images. So I think it's worth a try.
Totally agree. Actually, the next time I TE someone, if there's a quadricuspid, I'll make it a point. I'll try and prove it on subcostal on pictures. That's a good point. Thank you, Eamon. Anybody else?
Rudy, is there any value of transthoracic 3D? We tend to underutilize transthoracic.
Yeah, it's a great question. There's tons of like when picking out cases and pictures, there are lots of examples where you can make out the number of leaflets and the mechanism, especially the lead positioning with transthoracic. As part of our lab, we don't do it a heck of a lot often. I'm not sure.
Maybe I'll just point out Rudy, who has a lot of experience in the 3D transthoracic sort of like exploration. So you want to just comment on that point about using 3D transthoracic for tricuspid valve?
We had a 3D probe.
Come close.
When we had a 3D probe, I tried doing 3D on tricuspid valve. Obviously, you need a very, very good image quality to obtain a good 3D data set to play around with it. So again, it's underutilized. It can be. It's all practice. Practicing subcostal is one of the best view, or even the short axis. If you have a skinny person, short axis, personal short axis. You go
you can get off that.
a little bit medially.
Okay.
To get that view as well. I chatted with Dr. Wendy Sang one time about. She's very good at that, but we weren't able to make that happen. Like me going to the PGHs and learn more from her. It's not easy. It requires a lot of practice.
Well, the 3D of the valve is not easy on TE. Like even on TE, we're sitting there struggling trying to get really good leaflet definition, and so yeah, we do definitely appreciate that.
Wonderful. Any questions or comments or experience from our Sonographers colleagues? Do you find it challenging to image the lead, or?
Should we be doing more TEs for these patients? Given should we be doing more TEs for these patients, given options that are available now?
So the question is from our cardiology resident colleagues is that should we do more TEs on patients with lead related or lead in association with tricuspid regurgitation? I'll let you answer that first.
So I think, especially in patients who who have right-sided heart failure and that you're escalating diuretics, or you're struggling to treat them, there are options. Now there are a lot of structural intervention options that do not require reopening or revising the lead, right? So I think in those patients who you think have a reasonable life expectancy and quality of life is something that you are trying to think about, I would definitely I would definitely consider trying to reimage, get a better sense of what the mechanism is, and assess for candidacy for these interventions. And again, you know what it's like. It might like every 2 months there's a new device and there's a new new therapeutic option for these patients, and so. I do get the feeling, and because I saw all these patients in residency, that people say, well, it's lead-induced DR, well, let's just treat it as half-past, we'll put them on SGLT2 or something, right? Like, you try sort of medications, you try and bump up their diuretics, but I think forget that there are options. There are definitely options. These patients don't have to live with NYHA 3 symptoms at home. So
Now, I would just add to that, having practiced for quite some time now, like we used to throw our hands up. It's like that's too bad. Like, you have lead-related or lead and significant TR, we'll just treat you aggressively and diurese as much as possible, get your right heart down, and hope for the best. But nowadays, there's actually many more options, including leaflet end-to-end repair. There's a tricuspid percutaneous replacement, and also heterotropic valve replacement, as Dr. Unni has alluded to. I think it's back the question to actually how we can fix it rather than just leaving people on high doses of diuretics. So, I think, T is actually a great tool now that we have got all the X-plane or multiplane or as well as 3D. It allows us to actually understand this a lot more than what we could do about 6, 7, or even 8 years ago, as short as that. So I think there are lots more options. So yes, despite all the widespread, denial of lead-related tricuspid regurgitation, please send them along, and then we'll be happy to explore that for you or with you.